the lecture called The Risk Factors and Screening of Main Chronic Non-Epidemic Diseases in Children. First of all, I would like to remind you that non-communicable diseases, or NCDs, also known as chronic diseases, are not passed from person to person. They are of a long duration and generally slow progression. The four main types of non-communicable diseases are cardiovascular diseases, like heart attacks and stroke, cancers, chronic respiratory diseases, and diabetes. Risk factor is a factor such as a habit or environmental condition that predisposes an individual to develop a particular disease. Evaluated risk factors for cardiovascular diseases in children are the following: family history, age, gender, nutrition or diet, physical inactivity, tobacco exposure, blood pressure, lipids, overweight or obesity, diabetes mellitus, predisposing conditions, metabolic syndrome, inflammatory markers, perinatal factors. Children at high-risk category have the following conditions: manifest coronary artery disease, age of 30 years, clinical evidence, T1DM or T2DM, chronic kidney disease, end-of-stage renal disease, or post-renal transplant, post-orthopic heart transplantation, Kawasaki disease with current coronary aneurysms. Moderate risks include accelerated atherosclerosis, pathophysiologic evidence, Kawasaki disease with regressed coronary aneurysms, chronic inflammatory disease, human immunodeficiency virus infection, or nephrotic syndrome. The risk factors and risk behaviors that accelerate the development of atherosclerosis begin in childhood, and there is increasing evidence that risk reduction delays progression towards clinical disease. Measures of subclinical atherosclerosis have developed, including the demonstration of coronary calcium on electron beam computed tomography imaging, increased medical thickness in the carotid artery assessed with the ultrasound, endothelial dysfunction with brachial ultrasound imaging, and increased left ventricular mass with cardiac ultrasound. These measures have been assessed in young individuals with severe abnormalities or individual risk factors. In adolescents with marked elevation of LDL cholesterol due to familial heterozygous hypercholesterolemia, abnormal levels of coronary calcium, increased CIMT, and impaired endothelial function have been demonstrated. Children with hypertension have been shown to have increased CIMT, increased left ventricular mass, and eccentric left ventricular geometry. Children with type 1 diabetes mellitus have significantly abnormal endothelial function and increased CIMT. Children and young adults with a family history of myocardial infarction have increased CIMT, higher prevalence of coronary calcium, and endothelial dysfunction. Endothelial dysfunction have been demonstrated by ultrasound and plethysmography in association with cigarette smoking, passive or active, and obesity. In obese children, improvement in endothelial function occurs with regular exercise. Left ventricular hypertrophy at levels associated with excess mortality in adults has been demonstrated in children with severe obesity. Risk factors tracking from childhood to adulthood exist for all the major risk factors. Obesity tracks more strongly than any other risk factor. For cholesterol and blood pressure, tracking correlation coefficients in the range of 0.4 have been reported consistently across many studies, correlating these measures in children from 5 to 10 years of age with results from 20 to 30 years later. Having cholesterol or blood pressure levels in the upper portion of the pediatric distribution makes having these as adult risk factors likely, but not certain. Those who develop obesity have been shown to be more likely to develop hypertension or dyslipidemia as adults. Tracking data on physical fitness are more limited. Physical activity levels do not track, but not as strongly as other risk factors. By its addictive nature, tobacco use persists into adulthood, though approximately 50% of those who have ever smoked eventually quit. Type 1 diabetes mellitus is a lifelong condition. The insulin resistance of type 2 diabetes mellitus can be alleviated by exercise, weight loss, and bariatric surgery, but the long-term outcome for type 2 diabetes mellitus diagnosed in childhood is not known. As above, risk factors clusters such as those seen with obesity and the metabolic syndrome have been shown to track from childhood into adulthood. A family history of CVD represents the net effect of shared genetic, biochemical, behavioral, and environmental components. In adults, epidemiologic studies have demonstrated that a family history of premature coronary heart disease in a first-degree relative, heart attack, treated angina, percutaneous coronary catheter interventional procedure, coronary artery bypass surgery, stroke, or sudden cardiac death in a male parent or sibling before the age of 55 years, or a female parent or sibling before the age of 65 years, is an important independent risk factor for future CVD. The process of atherosclerosis is complex and involves many genetic loci and multiple environmental and personal risk factors. Nonetheless, the presence of a positive parental history have been consistently shown to significantly increase baseline risk for CVD. The risk for CVD in offspring is strongly inversely related to the age of the parent at the time of the index event. The association of a positive family history with increased CV risk has been confirmed for men, women, and siblings, and in different racial and ethnic groups. The evidence review identified all randomized controlled trials, systematic reviews, meta-analysis, and observational studies that addressed family history of premature atherosclerotic disease and the development and progression of atherosclerosis from childhood into young adult life. Physical activity is any bodily movement produced by contraction of skeletal muscle that increases energy expenditure above a basal level. Physical activity can be focused on strengthening muscles, bones, and joints, but because these guidelines address CV health, the evidence review concentrated on aerobic activity and on the opposite of activity, sedentary behavior. There is strong evidence for beneficial effects of physical activity and disadvantageous effects of sedentary lifestyle on the overall health of children and adolescents across a broad array of domains. Conditions under which children less than 3 years old should have blood pressure measured. History of prematurity, very low birth weight, or other neonatal complication requiring intensive care. Congenital heart disease, recurrent urinary tract infections, hematuria or proteinuria, non-renal disease or urologic malformations, family history of congenital renal disease, solid organ transplant, malignancy or bone marrow transplant, treatment with drugs not to raise blood pressure, other systemic illnesses associated with hypertension, evidence of increased intracranial pressure. In epidemiologic surveys of children and adolescents over the past 20 years, blood pressure levels are increasing, and the prevalence of hypertension and prehypertension is increasing, explained partially by rise in obesity. Breastfeeding and supplementation of formula with polyunsaturated fatty acids in infancy are both associated with lower blood pressure at follow-up. A DASH-style diet, which is rich in fruits, vegetables, low-fat or fat-free dairy products, whole grains, fish, poultry, beans, seeds and nuts, and lower in sweets and added sugars, fats, and red meats than typical American diet, is associated with lower blood pressure. The Child 1 diet, combined with the DASH eating plan, is an appropriate diet for children. Lower dietary sodium intake is associated with lower blood pressure levels in infants, children, and adolescents. Losartan, amlodipine, felodipine, fosinapril, lisinopril, metoprolol, and valsartan can be added to the list of medications that are tolerated over short periods and can reduce blood pressure in children from ages from 6 to 17 years, but predominantly are effective in adolescents. For African American children, greater doses of fosinapril may be needed for effective blood pressure control. Observational studies have identified sample populations that are at special risk for obesity as follows. Children with body mass index between the 85th and 95th percentiles. Children in whom there is a positive family history of obesity in one or both parents. Early onset of increase in weight beyond that appropriate for increase in height. This can be identified early, beginning in the first year of life. Excessive increase in weight during adolescence, particularly in black girls. Children who have been previously very active and become inactive, or adolescents who are inactive in general. An example would be a child who was previously participated in organized sports and has stopped, particularly in adolescence. There is good evidence for the effectiveness of combined weight loss programs that included behavior change counseling, negative energy balance through diet, and increased physical activity in addressing obesity in children older than age 6 years with a BMI above 95th percentile and no comorbidities. Dietary plans should be determined for each child based on a baseline body size, energy requirements for growth, and physical activity level. No studies defining an appropriate rate for weight loss in any age group were identified. For those with a BMI above the 95th percentile without comorbidities, the recommended weight maintenance result in decreasing BMI as age increases. With the BMI above the 95th percentile with comorbidities, the recommended gradual weight loss should not exceed 1 pound per month in children ages 2 through 11 years or 2 pounds per week in adolescents. The Child 1 diet is the first stage of the cardiovascular health integrated lifestyle diet. The diet was designed in mind for kids with high cholesterol levels, who are overweight, with high blood pressure, with high-risk medical conditions such as having type 1 or type 2 diabetes, having had a kidney transplant or heart transplant, chronic kidney disease, end-stage renal disease, or Kawasaki disease, and still having coronary artery aneurysms. With a family history of early cardiovascular disease, dyslipidemia, obesity, primary hypertension, diabetes mellitus, or exposure to smoking in the home. Most children with risk factors should transition to a Child 1 diet when they are 2 years old. Parents and pediatricians should then continue to reinforce Child 1 diet messages as these children get older. The Child 1 diet works to limit or avoid sugar-sweetened drinks, encourage kids to drink water, avoid trans fat, encourage high-fiber foods, limit sodium and avoid foods high in salt, encourage kids to drink fat-free unflavored milk, teach kids the appropriate portion size, which will be partly based on the estimated number of calories they need each day based on their age, gender, and how active they are. Encourage daily physical activity. Limit cholesterol intake to less than 300 milligrams each day. Teach healthy eating habits. Encourage a DASH-type diet rich in fruits, vegetables, low-fat or fat-free milk and other dairy products, whole grains, fish, poultry, beans, nuts and seeds, and lower in sweets and added sugars, fats, and red meats. Child 1 for preteens and teens. In addition to continuing to drink fat-free, unflavored milk, water, and limited amounts of sugar-sweetened drinks, older kids should be encouraged to follow healthy eating habits, such as eating breakfast every day, eating meals as a family, limiting fast food meals, continuing to eat high-fiber foods, watching portion sizes, and being physically active every day are also still important at this age. It is important to keep in mind that Child 1 diet is just the first step for children with high cholesterol. If after a 3 to 6 month trial of Child 1 dietary changes, a child continues to have high cholesterol, they should then move to a Child 2 diet, with only from 25 to 30% of calories from fat, less than or equal to 7% of calories from saturated fat, about 10% of calories from monosaturated fat, less than 200 milligrams per deciliter of cholesterol. Avoid trans fat as much as possible. The Child 2 LDL diet encourages the use of plant sterols, plant stenol esters, and water-soluble fiber psyllium to replace some fats in the child's diet. In contrast, the Child 2 TG diet encourages the replacement of simple sugars with complex carbohydrates and increasing omega-3 fatty acids. Keep in mind that a registered dietitian should likely help your child plan and follow their Child 2 diet, and may even be helpful for the Child 1 diet too. Screening recommendations for type 2 diabetes mellitus in childhood have the following criteria. Overweight, defined by the body mass index above the 85th percentile for age and sex, or weight for height above 85th percentile, or weight more than 120% of ideal for height, plus any of the two following risk factors. Family history of type 2 diabetes in the first or second degree relative, race, ethnicity, signs of insulin resistance or conditions associated with insulin resistance. Screening procedure includes the following measures. Age of initiation, 10 years, or at onset of puberty if puberty occurs at younger age. Frequency, every 2 years. Test, fasting plasma glucose. Acceptable, borderline high, and high plasma lipid, lipoprotein, and apolipoprotein concentrations for children and adolescents are shown on this slide. Please note, values given are in milligrams per deciliter. Among causes of secondary dyslipidemia are the following: exogenous, alcohol, drug therapy, corticosteroids, isotretinoin, beta blockers, some oral contraceptives, select chemotherapeutic agents, select antiretroviral agents. Endocrine metabolic causes: hypothyroidism, hypopituitarism, diabetes mellitus types 1 and 2, pregnancy, polycystic ovary syndrome, lipodystrophy, acute intermittent porphyria, renal, chronic renal disease, hemolytic uremic syndrome, nephrotic syndrome. Infections, acute viral or bacterial infection, human immunodeficiency virus infection, hepatitis, hepatic, obstructive liver disease or cholestatic conditions, biliary cirrhosis, Alagille syndrome, inflammatory disease, systemic lupus erythematosus, juvenile rheumatoid arthritis, storage diseases, glycogen storage disease, Gaucher's disease, cystine storage disease, juvenile Tay-Sachs disease, Niemann-Pick's disease. Among other causes are Kawasaki disease, anorexia nervosa, post-solid organ transplantation, childhood cancer survivor, progeria, idiopathic hypercalcemia, Klinefelter syndrome, Werner's syndrome. Major lipid disorders in children and adolescents are shown on this slide. As you can see, most part of the lipid disorders are hereditary and depend on the family background. Lipid assessment has the following evidence. Abnormal lipid levels in childhood are associated with increased evidence of atherosclerosis. The early identification and control of dyslipidemia throughout youth and into adulthood will substantially reduce clinical CVD risk beginning in young adult life. TC and LDL-C levels fall as much as 10 to 20% or more during puberty. Based on this normal pattern of change in lipid and lipoprotein levels, with growth and maturation, age 10 years, or range age from 9 to 11 years, is a stable time for lipid assessment in children. In the absence of a clinical or historic marker, identification of children with lipid disorders that predispose them to accelerated atherosclerosis requires universal lipid assessment. Non-HDL-C has now been identified as a significant predictor of the presence of atherosclerosis, as powerful as any other lipoprotein cholesterol measure in children and adolescents. The expert panel felt that non-HDL-C should be added as a screening tool for identification of a dyslipidemic state in children. Obesity is commonly associated with a combined dyslipidemia pattern with mild elevation in TC and LDL-C, moderate to severe elevation in TG, and low HDL-C. This is the most common dyslipidemic pattern seen in childhood, and lipid assessment of overweight and obese children identifies an important proportion with significant lipid abnormalities. Dyslipidemias can be acquired genetically, but also secondary to specific conditions. Lipid evaluation of patients with special risk diagnosis for accelerated atherosclerosis contributes to risk assessment and identifies an important proportion with dyslipidemia. Decisions regarding the need for medication therapy should be based on the average of results from at least 2 fasting lipid profiles obtained at least 2 weeks, but no more than 3 months apart. The goal is LDL lowering therapy in childhood and adolescence is LDL-C below the 95th percentile. The bile and acid sequestrants are medications that bind bile salts within the intestinal lumen and prevent their enterohepatic reuptake in the terminal ileum, resulting in the depletion of bile salts in the liver and a signal for increased production. The bile acid sequestrants commonly have gastrointestinal side effects, and these significantly affect compliance. However, they are safe and moderately effective. Statin medications inhibit hydroxymethylglutaridyl coenzyme A reductase, which is a rate-limiting enzyme in the endogenous cholesterol synthesis pathway. This results in a decrease in the intracellular pool of cholesterol, which signals upregulation of LDL receptors and increased clearance of circulating LDL-C. As a group, statins have been shown to reduce LDL-C in children and adolescents with marked LDL-C elevation of FH, defined as elevated LDL-C in the child in conjunction with a family history of elevated LDL-C and/or atherosclerosis or CAD, when used from 8 weeks to 2 years for children ages 8 through 18 years. Adverse effects from statins are rare at standard doses but include myopathy and hepatic enzyme elevation. Routine monitoring of hepatic enzymes and clinical assessment for muscle toxicity are strongly recommended for children and adolescents on statin therapy. Drugs that potentially interact with statins include fibrates, azo antifungals, macrolide antibiotics, antiarrhythmics, and protease inhibitors. Bile acid binding sequestrants may be used in combination with a statin for patients who fail to meet LDL-C target levels with either medication alone. The efficacy of the two agents together appears to be additive. Medication therapy is rarely needed for children with elevated TG who respond well to weight loss and lifestyle changes. When TG level exceeds 500 mg per deciliter, patients are at risk for pancreatitis and require care in consultations with a lipid specialist. Asthma attacks all groups but often starts in childhood. It is a disease characterized by recurrent attacks of breathlessness and wheezing, which vary in severity and frequency from person to person. In an individual, they may occur from hour to hour and day to day. This condition is due to the inflammation of the air passages in the lungs and affects the sensitivity of the nerve endings in the airways, so they become easily irritated. In an attack, the lining of the passages swell, causing the airways to narrow and reducing the flow of the air in and out of the lungs. It is well established that asthma is a variable disease. Asthma may vary among individuals and its progression and symptoms may change within the individual's experience over time. The course of asthma over time, either remission or increase in severity, is commonly referred to as the natural history of the disease. It has been postulated that the persistence of increase of asthma symptoms over the time is accompanied by a progressive decline in lung function. Recent research suggests that this may not be the case. Rather, the course of asthma may change markedly between young children, older children, and adolescents and adults, and this variation is probably more dependent on age than on symptoms. Most of the deficits in lung function growth observed in children who have asthma occur in children whose symptoms begin during the first 3 years of life, and the onset of symptoms after 3 years of age usually is not associated with significant deficits in lung function growth. Thus, a promising target for intervention designed to prevent deficits in lung function and perhaps the development of more severe symptoms later in life would be children who have symptoms before 3 years of age and seem destined to develop persistent asthma. However, it is important to distinguish this group from the majority of children who wheeze before 3 years of age and do not experience any more symptoms after 6 years of age. Until recently, no validated algorithms were available to predict which children among those who had asthma-like symptoms early in life would go on to have persistent asthma. Data obtained from long-term longitudinal studies of children who were enrolled at birth have generated such predictive index. It identifies the following risk factors for developing persistent asthma among children younger than 3 years of age who had 4 or more episodes of wheezing during the previous year. Either one of the following: parental history of asthma, a physical diagnosis of atopic dermatitis, or evidence of sensitization to air allergens, or 2 of the following: evidence of sensitization to foods, More than 4% peripheral blood eosinophilia, or reason apart from cause. As a conclusion, I would like to mention that chronic diseases require chronic care management, as do all diseases that are slow to develop and of long duration. Thank you for your attention.